So again, thank you for that nice introduction. And I'd like to thank Cesar Gulick for invitation to speak. I'm just sorry we are not live down in Miami with nice weather. We just had snow the other day here in Maryland. Now, before beginning, I am discussing the update of the classifications of radioiodine refractory. I always think it's good to have a little medicine and a good laugh, certainly in this crazy world of ours. So I wanted to share these three images with you. This is why aliens don't talk to us. And this one is, you're a chocolate lab, let me check. And the third one is about us physicians. No one can write the word help legibly. And this is a bunch of shipwrecked. And boy, I know about that one. So let's get down to work. Let's talk about radioiodine refractory disease and an update to the classifications in the year 2022. These are my financial disclosures. And I also have a PowerPoint disclosure, and that in any training program, and certainly our training program, our fellows, we taught our fellows to reduce verbiage. And I'm going to violate that rule because I'll put my email address up at the end. And if you email me, I'm happy to send out a set of my slides. Now, when one receives that, often the verbiage and the presentation's not coming along with the slide, so I've included more text, and that's how I'm violating that rule. This is an article that's actually been previously published with the data that I'm going to present, and my email again will show up at the end. So my objectives are really to distill the classifications that have been proposed by various groups and societies, to list the sources of those and literature supporting those classifications, discuss the limitations of those classifications, and that's the really meat of the matter of my presentation, and to also submit and propose to you some next steps for revisions of the classifications of radioiodine refractory differentiated thyroid cancer, and submit some potential approaches and caveats to help manage a patient from being excluded from an I-131 therapy because they're being categorized as radioiodine refractory, when in fact they may benefit, and these patients have metastatic disease and they're running out of options. So we want to try to give them every option that we can. And then discuss some future areas of research. So this is just acknowledgement of some of the previous work from Rose out of Paris, France in 2010 with a reference, a panel of experts that was sponsored by Sci Strategy in 2012 in Pisa, Italy, with Dr. Schlumberger submitting a manuscript from that, and multiple other articles that have been published by Mike Tuttle, who I think is on the program shortly, Wendy Sachs from LA, and Brian Haugen from Colorado, and many more. And it's on this efforts of these individuals that the definitions of radioiodine refractory have been developed and refined, and they should receive the accolades for all their initial work. Also, the Martinique Working Group, which I think the first year, I can't remember now, was 2018, but was composed of ETA, ATA, EANM, and SNMI, also looked at this regarding radioiodine refractory TDC, and that publication was lead off by Mike, and that's available with the reference noted below. But radioiodine refractory disease is very, very controversial. And I've shown this slide so many times that I almost removed it, but this slide just captures the whole subject of radioiodine refractory so well that I just could not remove it. Now, I hope the audio came through, but sometimes the audio doesn't. But if you watch that remote, you realize that the gentleman cleaned the wrong car from all the snow. We all think we're doing the right thing and our intentions are good, but are we always doing the right thing for the patient? Again, my objective is to inform you regarding some of the major limitations regarding these definitions, and I prefer the word categorizing, of the patient's differentiated thyroid cancer as radioiodine refractory disease. Now, this was the 2015 ATA guideline recommendation number 1. And basically and this is verbatim, when a patient is classified as radioiodine refractory, there is no indication for further treatment. Now, I have no problem with that, and I agree with that statement when a patient is truly radioiodine refractory. But the operative word is truly. And actually, with the work of Jim Fagan and Alan Ho, this statement actually may not be true anymore, or the work of Jaber from MD Anderson and Rothenberg, and we'll talk about this a little bit later with the redifferentiation that Jim's gone over so nicely. But the issues for me are really that the first classification that's been proposed and used over the years is frequently taken as a definition. And a definition is defining what the term is, or sacrosanct or inviolable. And in fact, the limitations are becoming, at least in my opinion, less and less frequently discussed. And even I don't see them extensively discussed as I think they need to be discussed. Hence why I'm doing this presentation. Now, this is another video slide that I like that is very important regarding the philosophy. So I'll explain that after you watch the video, and I hope the audio comes through.
We have, folks, a large pepperoni pizza.
And a Pepsi, please.
A Pepsi. Sure thing, Curly. Here you go, Cupcake.
Thank you.
I want you to listen very carefully to what I'm going to tell you. We both know I ordered a Pepsi-Cola, and now you've insulted me and my entire family by offering me this. Whatever it is, for being a civilized person, I'd like to give you a chance to make amends. To peace. Here you go.
Thank you.
Folks.
Now, I don't know if the audio of the video came through, but the message that I was trying to do through the humorous video is I'm really not trying to tell you what to drink, whether it's a Coke or a Pepsi, and I'm not trying to tell you what to do. Again, what I'm really trying to do is that despite guidelines, they have disclaimers that frequently say that what is in the guideline is not etched in stone. But what you really need to know, and what I want to inform you about, is their limitations. And one of my favorite quotes that I frequently use is, "It ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so." And what happens is people come out with definitive definitions, and they believe that what they know is true, and it just ain't so, hence the limitations. So let's look at these classifications. And again, all the credit go to these previous authors for developing this, laying the groundwork. But as with all things, they need to be reevaluated and reclassified. Classification number 1 is malignant metastatic tissue does not concentrate radioiodine on a diagnostic scan. Not a sacrosanct classification and should not be a definition. In fact, in my opinion, it's a weak classification. Poor scan preparation, no history of recent iodine load, no checking of urine iodine levels, appropriate preparation with thyroid hormone withdrawal or checking TSH. Limitation 2, not all radioiodine scans are created equal. Here's a scan, posterior view. I don't know if you see my arrow, but I hope so. It did for Dr. Luster and others. This is two potential areas of activity in the lungs or rib. This is another image clearly showing these two areas and an additional area. All this is in panel B is just about technique. It's an image performed the next day. So this really makes a difference in the quality that you get from your radioiodine scan. And I often think it's one of the reasons that many institutions don't find their scans very useful. And there's many enhancing techniques that can be used. Parallel whole collimator, pinhole collimator, longer acquisition time, earlier delayed initiation of images, just like the one I just showed you that was performed the next day, altered contrast and brightness on display of the monitor, imaging driven by patient-specific history that you go back and take spots, most importantly, SPECT-CT. And this has all been published in an article in Thyroid in 2019. Again, that not all scans are created equal, and these well-known but frequently unperformed techniques to improve assessment are not performed. It's like ultrasound. It's operator dependent. It's not like a chest x-ray, and most chest x-rays are chest x-rays or chest x-rays. Limitation 3, most diagnostic scans are negative, even with appropriate technique, but the post-therapy scans are positive. This is 6 studies that have been published. All of these looked at negative diagnostic scans with various techniques and then did a blind I-131 therapy. So they said, well, we really don't know, but we're going to give them iodine anyway. They're running out of options. They've got metastatic disease. Their life survival is decreased. And the post-therapy scan showed uptake on the post-therapy scan of 69%, 25, 63, 64%. And that's not just all. There's plenty more in the literature that evaluated the same thing. Pacini had 94%, down to 50%. So a negative diagnostic scan is not a reliable classification, even with appropriate imaging technique. Classification number 2 is malignant tissue does not concentrate any iodine, none seen. It's not really that it doesn't concentrate it. It may concentrate it, but it's not seen on the post-therapy scan. So it may be avid, but not visible. Now, this is one of the better classifications. However, it is not perfect either. This is an interesting study from Salvatore in 2013. And he looked at imaging post-therapy in 3 days and 7 days. And out of 134 patients, 108 were positive on both studies. That's pretty good. So that would suggest that the day you image really doesn't make a difference. And many of the guidelines say 5 to 7 days. But if you just looked at day 7, and many facilities will image at day 7. We did day 7 for many years. And you sit the image at day 3, you'd have missed 10 out of 134 patients. 7.5% would have been read as negative and ergo radioiodine refractory. If you imaged them at 3 days and it was negative, and you didn't do a 7-day scan, 12%, 16% of the patients would have been classified as radioiodine refractory, when in fact, they do have avid metastatic disease. Now, an important footnote, don't quote me as saying that if you're positive on a post-therapy scan, you're going to get a good response from the radioiodine therapy. I'm not saying that, and I'll also discuss that more. Now, Salvatore's study is not the only study. There are many of them, Hong, Li, Chung, Kodani, and they looked at various numbers of patients and days, and the time that you image makes a difference. So classification number 2, negative post-therapy scan, it's good, but not sacrosanct. You need to know the limitations. Now, the question that I frequently get asked is, how do I handle this? Well, you could perform a scan at 3 and 7 days, but the odds are that's not going to happen. I mean, I even got pushback from my administrator. That's time, that's imaging. Patients got to come back twice. But you could do scans at 3 to 4 days on a routine basis. And if negative, and let's say in patients, selected patients that have a very high risk of metastatic disease, or you know they have metastatic disease, and you really want to see if they have avid uptake to consider a therapy, repeat at 6 to 8 days. And I think this is a good, reasonable approach. Classification number 2, good, but not sacrosanct. You need to know the limitations. Classification number 3 is the tumor loses the ability to concentrate radioiodine after previous evidence of radioiodine disease. This is exactly the same concerns as the previous 2 classifications. Classification 4, radioiodine is concentrated, and all of these are verbatim. Radioiodine is concentrated in some lesions, but not in others. In my opinion, this should not be a classification. So I have 4 bone lesions, 3 bone lesions that take up radioiodine, but 1 lesion doesn't. Does that categorize this patient's disease as radioiodine refractory? Why not treat the non-avid I-131 bony lesion with focally directed treatment? That's surgery, XRT, radiofrequency ablation, cryotherapy, embolization, and administer I-131 then after that to treat the other 4 lesions. In my opinion, this should not be a classification. Classification 5 is metastatic disease progresses despite significant concentration of radioiodine. In my opinion, this is one of the most important classifications. However, there's always a however, the term progresses really needs to be a specific criteria and not just the fact that the patient is progressing. Now, I admit, and when Matt Ringel from Ohio was with us for many years at a hospital center, we both approached this the same, that the patient progressed, then I-131 was a failure. But we've rethink that. If a patient is progressing after a therapy with an activity of 100 millicuries of I-131, why do we classify that patient as radioiodine refractory? Why isn't that considered a radioiodine refractory physician? Likewise, if the patient's progression-free after an I-131 therapy, let's say for 12 months, 14 months, 16 months, after lenvatinib, and that's considered pretty good, then after daily administrations of lenvatinib, why is a patient considered to be radioiodine refractory if that patient has progression-free survival for 14 months after 1 administration of I-131? I think the word progresses needs to be further categorized. And why not give another I-131? I'll talk about this in more detail later, but the key is not just progression, the key is really duration of progression. Now, classification 6 is the patient has received a total of 600 millicuries cumulative dose of I-131. It's my opinion also this should not be a classification. And why would we pick 600 millicuries? Well, I understand where the developers, and again, they're all good, based upon reports in the literature, and the 2 key ones were Durant in 2006, and Huang in 12. And it was unlikely that the patient would benefit with I-131 activity above 600 millicuries. Makes sense. But we really need to go back and look at that data regarding 600 millicuries. Now, Durant reported 4% of patients had a response if they got over 600 millicuries. Well, that's not very much, but the reality of it is these patients are running out of options, and these 4 patients are going to lose a potential therapeutic effect from an I-131 therapy. Now, it may not be all 4%, but is there a way that we can assess that? And Huang reported 12% of patients had a response over 600 millicuries. So if they had more than 600 millicuries and responded to the previous therapy and had an improvement, they were progressing, but with the therapy, they became stable, a partial regression or progression-free survival, or had remission, why not give them another I-131 therapy? But if they had, let's say they got an activity administered at 300 millicuries or 600 millicuries and didn't respond, then consider them radioiodine refractory. This should not be a classification. Progression is, again, in my opinion, the better specific criteria for radioiodine refractory. Now, Those are the major 6 that have been proposed in the literature. There's some other variations of those, but let's at this point look at some proposed next steps for radioiodine refractory thyroid cancer. A multi-specialty international committee has been formed called the International Committee on Classifications of Radioiodine Refractory Differentiated Thyroid Cancer, long title. And it's composed of members from representatives from the ATA, the EANM, ETA, SNMI, F.A.C.P, the All Latin America Nuclear Medicine Society, the Canadian Society, the India Society, from patient representative groups such as THICA and multiple other additional individuals. And we've already been meeting and working through these classifications to better define them. And hopefully we will put a publication out to try to address our findings and possibly recommendations. But in place of implementing cookbook definitions, and that's understandable, that's why we have guidelines, but we recommend the practice, and I recommend the practice of medicine. And I think where we'll head with the ICCRR is more of a diagram that came out of the ATA, which really shows a likelihood ratio of radioiodine refractory based upon the criteria. Now, in the interim then, consider referring the patient. Do not consider a patient to be radioiodine refractory just because the patient's diagnostic radioiodine scan is negative. Do not consider the patient to be radioiodine responsive just because the patient's scan and post-therapy scans are positive. Remember, not all scans are created equal. Assess the quality of the diagnostic scan. And there are whole groups of things that need to be assessed, especially if one's an endocrinologist trying to assess the quality of the scan they're getting. And likewise for radiologists and nuke med physicians. A predetermined cumulative prescribed activity of I-131, such as 600 millicuries, should not be a sacrosanct definition. It should be the patient's response to the previous I-131 therapy. And do not use just the criteria of progression, but the character and the duration of the response and how much I-131 was administered. Now, here's a warning about this next slide. It's very complicated. In the interest of time, I'm not going through it. If you did ask for the slides, this will come with it. But what this emphasizes is consideration of 2 very important factors: the administered activity of I-131 and the duration of stable disease or remission after that administration. 11, what are the criteria for a response? That has to be considered. Structural response, RECIST criteria. One doesn't necessarily need to use a RECIST criteria, which is used for research study. It could be a modified RECIST. What thyroglobulin response? What duration of response? All of these are important. And also, what's the criteria for the patient? What's considered acceptable? Number 12, additional factors that have to be considered: amount of activity administered, as we've already discussed, frequency and severity of side effects. Is the patient a minimalist or a maximalist? Mike Tuttle introduced me to this book by Groupman and Hartspan, outstanding book, not just for doctors, but for patients. And having been a patient recently, it was very valuable. And also, are you a minimalist or a maximalist? And how should you affect your patients as their physician? 14, consider referring the patient for clinical trials using trametinib or dapirfenib. And in actual fact, as I'll comment more in a minute, maybe even using it clinically, using a MEK inhibitor and or a BRAF inhibitor. This is, Ben showed Alan Hose. I decided to show Jabers from MD Anderson, and his patients were treated mostly with trametinib and or dapirfenib, and they were not necessarily on a study to assess whether trametinib and dapirfenib would help redifferentiate, but they were receiving it to evaluate the MEK and BRAF protocol, not the scan results, or they were on it clinically. And there's a study by Rothenberg that shows the same thing. And they had dramatic, 7 out of 13 cases with dramatic redifferentiation. And now in our facility, and I know other facilities, if the patient is already on trametinib or vemurafenib and dapirfenib, we will consider clinically doing a scan at 4 to 6 weeks. So this is already here. This completely changes the paradigm of classifications of radioiodine refractory disease and will be one of the most difficult things for our committee to really try to work through. But selection of patients per Jim Fagan's presentation will be very, very helpful as we learn more and more. Proceeding in the interim is also the option of a blind I-131 therapy with either an empiric or dosimetrically guided I-131 or a 30 millicurie exploratory probe scan, which I won't go in here, but it will be available if one desires to learn more about that. In conclusion, the various authors who really have laid the groundwork need to be complimented for their pioneering time and effort. The classifications of radioiodine refractory disease are just not sacrosanct, and one should know the limitations of those classifications. And it's time to update the classifications, and the ICCRR will. I would expect something out about this time next year. This is a long process with the committee, and we're using the Delphi approach, and it'll be very good. So as a reminder and inclusion, I'm not trying to tell you what to drink or to do. You have to make that decision, practice medicine, and I hope I have at least informed you of the limitations. And remember this video. We really want to do the right thing. We think we're doing the right thing, but we don't have a little click monitor that will, when we're done with a therapy or better prior to the therapy, tell us what's the best option. This is my previous division at Washington Hospital Center. They've been instrumental in our management of our thyroid cancer population. And this is some of the research staff that I work with. And I thank them very much and look forward to a post-COVID party. And my email address is listed below. And you are welcome to email me directly, and I will send out a copy of my slides. And with that, I think we're early, saving maybe 2 or 3 or 4 minutes, and I will turn that back over to our moderator. Thank you all very much.